Thanks so much. I'll try and go through this quickly. I think obviously structural heart is sort of in its infancy in India. There aren't a lot of centers doing it. I mean, a lot of the restrictions are more cost as well as others. The presentation of the patients is different than in the U.S. Much more at a younger age, more rheumatic disease. I think probably potentially more bicuspid disease. But I think it is going to evolve, and I think a lot of the barriers for it to evolve will go away. We need sort of lower cost systems and all those things, but those will come with time. I'm going to just go through our experience here, and hopefully a lot of the mistakes that we made won't be repeated, and that's sort of the goal for all of these sessions. These are the typical patients that we see. Severe bicuspid. This one is a tricuspid, but we're seeing more and more bicuspid disease, even in 80-year-olds. 10% or so. But you see here, preserved LV function, severe AS, and this is a patient that got a Sapien 3 valve, completely uncomplicated procedure. This one was done asleep, although we do the majority of our patients awake at this point. This was early in our experience, but the final result showed very minimal leak. An excellent result, and the patient went home on post-op day 1, and that's sort of our goal. Most of these goals now is to get the patient to get home on day 1, and we don't succeed all the time. It's probably about 30% day 1 discharge, but 70 to 75% by day 2. And so this is sort of an evolution. This was the first case I was involved in 2005. Alain Cribier was our proctor. It was an antegrade transvenous transeptal procedure where you went right atrium to left atrium across the mitral and externalized the wire. And at that time we only had one valve, and we sized the valve based on a transthoracic 2D echo. We put a 23 millimeter valve. That image went away quickly, but look at that aortogram. Completely undersized that valve. That valve isn't even reaching, but we didn't understand how to size. That patient died on post-op day 2 just from multi-organ failure from cardiogenic shock. This was our second case. We did it 2 days later. Again, Alain Cribier was our proctor back in 2005. And in doing the antegrade approach, we lacerated the mitral valve. The stiff wire is not protected. It lacerated the mitral valve, and she was tried to be open, but basically died on the table. And so we did 2 cases in 2 days, and they both died. One acutely on the table, one from heart failure. And at that point, we decided in the U.S. Edwards stopped that transvenous trial, saying this was, although Alain Cribier had done a bunch of procedures, this was not a generalizable procedure. It's not something that we could sort of take to the general community. And at that time, John Webb was working on a retrograde transarterial approach similar to a BAV. And he'd done a bunch of cases. So the trial was halted, and we restarted with the retrograde approach in about a little less than a year later, in February of 2006. We did our first retrograde transfemoral approach. And this was basically a Sapien valve, the original Sapien, and the iterations went through from the original Cribier-Edwards, which was equine. I mean, the original valve, which was equine, to Cribier-Edwards, which is bovine pericardium. But this valve was basically crimped on a Z-Med balloon and advanced across the valve. And so we did our case. It was done through a cut down. It was a 24 to 26 French sheath. And the case went well. And actually our first 7 cases went well with the retrograde transarterial. But on our 8th case, our overall 10th patient, uncomplicated TAVR, but on extubation, patient had dense hemiparesis. And cerebral angiogram showed slow flow with microemboli. She was discharged to a nursing home, but died 5 months later after sort of a disabling stroke and never really recovered function. And so this is our first experience with embolic complications with TAVR. And so they are a concern. I think they've gotten less, but they were an early concern. Yeah, so that was patient number 10 overall. And then the next patient was this patient that we ruptured the iliac. We weren't really screening these patients effectively. It was an angiogram, we looked at a CT, but we really didn't understand the limitations. And so this patient survived, fortunately. We got balloon control, we went to the OR, had an aortoiliac bypass. But when you look at it, this patient had dense calcium. And we'd never say that patient was appropriate. but we weren't doing CT reconstructions. We were getting a angiogram mostly. Now, angiogram, it looked okay, and the CT, we thought it looked okay, but it wasn't a careful screening. And so we learned, and so now we do all of our own screening. We look at the CTs on these workstations and do the reconstructions. And so that, we learned vascular complications. The next patient did okay, but then the patient after it, we had real difficulty crossing. There wasn't a tip deflecting catheter. Basically, it was a little bit of a horizontal aorta, not terrible, but the wire crossed in the commissure and we had difficulty crossing. This video is not playing, but you can imagine what was happening. We had a buddy balloon, we were trying to re-balloon, we couldn't get it to cross, and in doing so, we unzipped the aorta. And these are, unfortunately, these are still images, but this is the true lumen, this is the false lumen of the ascending aorta. So in 3 of the 4 cases, we had a stroke, an aorta iliac avulsion, and an aortic dissection. And it was, you know, these experiences sort of push your confidence in the technology. And in the initial feasibility trial of retrograde transfemoral TAVR, we did 29 patients in that trial. And we had 5 major vascular complications, 3 iliac avulsions and 2 aortic dissections, both of which died. We had 3 strokes, and we had lots of other complications that we learned that it was not such a straightforward procedure. And it's not what it is today. And a lot of it, and so a lot of the lessons learned are which cases to do in the screening. And I think that's where a lot of these meetings, as technology evolves and is distributed, the learning can come from these early mistakes. And the same is going to be true as we go forward with transcatheter mitral. You know, mitral valve therapy started around the same time, but they're much further behind. And TMVR is a field still in its infancy, or a toddler stage, if you want to speak. But we're going to go through these same mistakes, and so we have to be patient with it. And we learned a lot from this experience. We learned that different complications occur. We learned that not everyone with this large sheath is going to be a transfemoral candidate, and that we're going to need some patience. And so we started with our transapical approach in December of 2006. We did our first patient, did well, got extubated on day 0. But this was an elderly, frail woman. Her BSA was like 1.5. She was tiny. She had this small, thick heart, but she never really recovered and died from heart failure. And so, you know, and in this TA experience, we also learned about sizing. You know, we put a 26 millimeter valve in a patient that had a 25 millimeter annulus on transthoracic. We had 4+ AR. We tried to post-dilate, then we created central AR. She eventually went to the OR because she just had wide open AI, and we had sort of flared the valve open. And this was, again, at the time that the learning was going on, that the annulus is not a circular structure. You know, we were taking this 2D measurement off axis. We take the parasternal long axis, make sure we can see both leaflets. And if you're seeing both leaflets meeting in the middle, you're taking this plane, because that's what you're cutting. When even if we're going to take a 2-dimensional measurement, the perpendicular one is where you're not through a leaflet, because there are 3 leaflets if it's a tricuspid valve. On the other side, you're not going to see a leaflet insertion. And so we were doing the worst case scenario in terms of sizing. We didn't understand how to size it. And so over time, this learning evolved, and we learned that we really need 3-dimensional imaging. Even biplane TE wasn't enough, and so this is where it really evolved with multi-slice CT. And I think imaging and our understanding of imaging and advances in imaging has, for the field of structural heart as an interventional community, has been the biggest advance. But the devices have really iterated, but our understanding of and the ability to plan the procedure, because technically the procedure is easy. It's all about the planning for the procedure that's most challenging. So I won't go through the rest of our experience, but we had a lot of complications in our first 100 cases. Everything that we've described. This is our coronary occlusion, which was patient number 61, and we managed to get through it, and we learned the differences of why coronaries occlude. It's not just from the left main being low. If you have a short sinus and a phase sinus or a long leaflet, we have to model what that leaflet's going to do when you deploy this valve, because it's not the prosthesis that's occluding the left main, it's the native leaflet being pushed up against it. So, you know, there are people that are working on modeling programs to try and model where these leaflets are going to go. And we're not at that point. We don't have a lot of this software. There are companies out there that do offer it, but they're still not great. In your mind, you have to say who's high risk. So if somebody has sinuses of 35 millimeters wide and their left main is low, you're not going to occlude it because there's still room for that native leaflet to sit. But if you have, your sinuses are narrow, even if your left main is tall, if that left coronary leaflet is long, you can occlude. So it's not a simple thing as annular height. It's multiple factors, and that's where the 3D imaging of the aortic annular complex, meaning left main height, left leaflet length, bulkiness of calcium on the left leaflet, and width of the sinuses all play a role. And we have to image that and try and image the entire structure. So we went through these series of events and complications, and we learned. And with the initial data, we helped build the evidence base, right? I mean, I think compared to a lot of other fields, I mean, cardiology gets criticized a lot, but one thing cardiology and cardiac surgery have done is collect the evidence. What is necessary? What are the risks? What are the outcomes? And we've collected rigorous evidence, and it started in terms of TAVR with the PARTNER trial. And the original PARTNER trial was cohort B, where patients who were not surgical candidates, and what we saw was that it was compared to medical therapy, and there really never been a trial of medical therapy with aortic stenosis, that TAVR improved survival. And you know, by the absolute numbers, it's a dramatic improvement in survival. It's a 20% reduction in mortality, and so it's a number needed to treat of 5, which is incredible for any sort of therapy to improve survival, for a hard endpoint like survival. But in the end, these patients were sick. Even in the ones with a successful TAVR, there was a 30% mortality at a year. But that was due to the comorbidity in this patient population. Then PARTNER cohort A compared it to surgery in high-risk patients. Again, non-inferior to surgery. And these, again, high mortalities, about 25% a year, and by 5 years, about a 70% mortality in this elderly comorbid population. But the PARTNER trial was important. It gave us a large evidence base, right? I mean, it was 700 patients in the surgical arm, another 300 plus in the cohort B, the inoperable arm, and we published about 60 manuscripts from it. We learned bleeding bad outcomes. And to the company's credit, they let us publish, they gave us the data sets, and we published all the ugliness of the field, the bleeding complications, pacemaker rates, all the things that lead to bad outcomes. And I think that's what's helped iterate and evolve the field. But at the same time, the PARTNER trial, we should stop discussing the data. This trial was started in 2007. At the time the trial started, there were three centers in the trial that had experience with TAVI, right? The other 22 centers did not. And you were comparing a field in its infancy with the first generation device to the most experienced surgeons at high volume centers. So yes, it was an important trial, but it does not represent the contemporary results of TAVI or TAVR, and we have to move on from it. It helped define what are the potential risks, but we have to move on. And there was more evidence building that TAVR may have some real benefits. The core valve high-risk trial was the first one to suggest that maybe TAVR may be superior to surgery in these elderly patients. You know, if you look at these 1-year endpoint of all-cause mortality, it's about a 5% lower with TAVR than surgery at 1 year in the core valve high risk. The PARTNER 2A trial was again this one over 2,000 patients, intermediate risk, randomized between surgery and transcatheter valve. And they were divided based on whether they were a transfemoral or transapical group. At this point, the devices were still large. About 25% of the patients were transapical. And we've seen that transapical TAVR have much worse outcomes. And so that's important when you look at it, right? Because if you look at the overall cohort, it was non-inferior. But if you look at the transfemoral cohort from PARTNER 2A of intermediate risk patients, and this was not a small population, this was 1,500 patients, and they were randomized, that TAVR was actually superior to surgery, and this was with the Sapien XT device, p-value of 0.04. Again, a 2-year endpoint with disabling stroke or TAVR, disabling stroke or mortality, there was about a 4% reduction with TAVR compared to surgery when you did it from a transfemoral approach. And that's the one thing that we've learned. Transfemoral TAVR is different from everything else, and I think that's key. When you do it from a transfemoral approach, it's a different procedure than when you do alternative access, especially a transthoracic approach like transapical. So the core valve with their intermediate trial, again, showed non-inferiority to surgery. And where we are now, the Sapien 3 device was a registry, and it compared to the surgical outcomes in the PARTNER 2 cohort. So it took the surgical arm of PARTNER 2A, and you compared the outcomes with these 1,000 patients, and the mortality was less than with surgery. And the reason mortality was less, just going back, you see all the difference in mortalities in the first 3 months, right? It was 30 days, 1.1% versus 4. but that separation occurs early. And the reason the separation occurs early is major complications were less with TAVI than stroke. 1% disabling stroke versus 4.4 in surgery. This is with neurologists seeing the patients. And then other complications were much lower. Bleeding, vascular, PVL, acute kidney injury were all low, AFib were all lower with TAVI than surgery. And those the bleeding, AFib, and acute kidney injury and stroke all lead to worse outcomes after surgery. And it's those lower rates of those complications that led to the superior outcomes with TAVI in the short term. And it was a much quicker recovery. Median stay in this trial was 3 days, and it's even less now. But the one limitation still remains: we don't know the durability. And so to become a routine part of the algorithm, we need better durability data. We have 5-year data from Partner 1, but that was a first-generation valve. We don't know what the data is going to be. I don't expect it to be as good as a surgical valve. We need to keep that in mind. And the guidelines are challenging, right? This is the 2017 iteration of the guidelines. And for high risk, TAVI got a class 1 indication. For intermediate risk, it was a 2A as an alternative to surgery. The reason it was a 2A instead of a class 1 is they said there was only one randomized trial. However, the second randomized trial, the CERTAVI data that I showed you, was presented 1 month after these guidelines were released. So it's hard for these guidelines to keep up. But what this data has done is when we started TAVI in that early iteration, those first 5 years, we said, okay, which patients are not good surgical candidates? So we took the patients that weren't going to do well with surgery and did TAVI. But now the conversation's different. It's who does well with TAVR. We have a better understanding. If somebody has no calcium in the LVOT, a good angular size, good femoral access, and really nothing, and good renal function, I can tell you their mortality in intermediate risk patients in the last year, we haven't had a mortality, right, of about 250 intermediate risk patients. If you choose those patients with the right anatomy, you know the outcomes are going to be good. And the reasons that these have improved is we've gotten, as I said, much better with pre-procedural imaging and pre-procedural planning. Procedural technique has evolved. We do a minimalist approach. We don't put Foleys. We don't put necklines. We do patients awake if possible. We do percutaneous access and closure. So the procedural technique has evolved as well. Patient screening. We don't do the patient with oxygen-dependent COPD. Right? Those patients are not going to do well even if you fix their aortic stenosis. Their mortality at a year from their comorbid conditions is greater than 50%. You're not going to benefit that patient. And then finally, the devices have definitely gotten better. Sapien 3 with a 14 French sheath, Evolut R with a 14 French sheath are much easier, much safer for the patient. But imaging the valve is what we really evolved, and it's become instrumental, as I talked about earlier, and I'll skip through this. But we've just learned that we need to better size these devices and that 3D imaging is crucial. And I think as you're starting your program, I think understanding the imaging, that is the most important concept. And the other thing I will say is immerse yourself in the patient and understanding it. You have to review the imaging, not the radiology report. The radiology report may say the vascular access was adequate, or they say minimal size was 6.5, but that's not enough. You want to know where that calcium is it tortuous, and you need to scroll through the imaging if you're going to do it. And then, as I said, learn which patients you shouldn't treat. There are those patients that are dying with aortic stenosis rather than from it, and those patients shouldn't be treated. So those patients with severe frailty that are demented, severe COPD, child's class C cirrhosis, they're not going to get better. Their risks with TAVR are higher, and they're also not going to get better after the procedure. But the patient that's 70 years old that has a porcelain aorta or that had prior CABG, that has a lima adherent to the sternum, who's functional and active, those patients are going to do very well. And so differentiating that is important. Large data sets can help with that. When you look at the 1-year outcomes from TVT, for example, you see the COPD results. If somebody had severe COPD, there was a close to a 2/3 increase, 60% increase in mortality. Same thing with end-stage renal disease. But their patients are on dialysis, nearly 50% mortality at 1 year. So, concomitant MR. If somebody has severe AS and has severe MR due to a flail leaflet, you're not going to fix the MR by fixing the AS. So in that patient, again, even if they're higher risk, surgery is probably the only option. And one of the things is patients are going to drive you for a less invasive therapy. And that's okay as long as it's an appropriate therapy. The 75-year-old re-op whose surgical risk score is still 3% or 2.5%, sometimes we say TAVR is appropriate for that patient. but that's after a conversation. Because what the patient needs to understand is if they're 75 and they get TAVR now, and they don't have an option for valve-in-valve because they have a small annulus or something, then what if the valve fails in 7 years? And at 82, they're committing themselves to a higher risk surgery. And if the patient understands that and you have a conversation, that's appropriate. But I think it's important to have those conversations, the limitations, but at the same time, if it's a 90-year-old re-op, we're not worried about their second procedure. But a 70-year-old, 75-year-old that you're seeing, you do need to worry about that. And so the right calculation is not simply a risk score. It's about life expectancy, it's about comorbid conditions, their expected quality of life, what their goals of care are, things like that, right? I've treated patients with cancer where the oncologist says their prognosis, if they have prostate cancer, prognosis is probably 5 to 10 years. That patient's, 75, and our surgeons have said, yeah, it's probably appropriate, right? The durability argument, as long as everyone understands, and that patient, it may be appropriate. And so those are the important conversations. And in the future, we need to understand this better. But we also need to continue to iterate devices. One of the things with TAVR is in the last decade, there's been a rapid evolution of the devices, and that's really made it better. But there's also been evolution in procedural technique. There's a lot of, we are not, there are centers that do every patient awake. We're not that center. However, we do try to do patients awake if they have good anatomy. And there's a move towards doing it awake. And the advantages of doing it awake are you minimize some of the complications of anesthesia. Putting an AS patient to sleep has risks. Intubation, extubation, esophageal injury from the TE, things like that. And what you've seen, this is not current data, but this is up to 2016, there's been increasing amounts of patients being done with moderate sedation. And as I said, it's a growing movement. This analysis from the TVT registry suggested there was a mortality benefit to doing the patients awake. That's not clear. This is not a randomized trial. There are challenges with it and everything else. But there may be some benefits. But at the same time, if you have a patient with a risk of left main obstruction or severe LVOT calcium or borderline sizing where assessment of AR is crucial, I don't do that patient awake. If they have high-risk features, I do that patient asleep. But if they have ideal anatomy and you can do it awake, then I do that patient awake. You also have to have a conversation with the patient. If somebody has really decompensated heart failure or has significant cognitive issues that they can't lay still, lay flat, especially early in your experience, you want to be focused on the procedure. You don't want to be focused on trying to keep the patient from moving the leg or doing something else. So early on, it's maybe better to do more cases asleep than awake. That way you can concentrate on the procedure as you go forward. Other things that we've evolved is, yes, stroke rates have come down. As I said with the Sapien 3 data recently, major stroke is 1%, any stroke is around 2.5%. But still, we can continue to potentially reduce that further. And there's been several attempts, trials to demonstrate benefits with embolic protection devices. The TriGuard device, which is basically a deflector, it's done through a femoral access sheath. It's like a surfboard. It's a mesh that sits across the cerebral vessels, and the idea is deflects debris from going to the brain. They're in their randomized clinical trial right now. Hopefully we'll finish enrollment within the next year or so. The Sentinel device, I was fortunate enough to be involved in their clinical trial. It is basically put through the right radial, and it's a single catheter with 2 filters on it. There's a proximal filter that deploys in the innominate, and this protects the right carotid and right vertebral, and then it flexes around, and another filter goes in the left carotid. The left vertebral is not protected. We did a randomized trial with this device in the US and Germany, over 300 patients. The primary endpoint was an MRI endpoint because we couldn't do a large enough trial to have clinical stroke reduction as an endpoint. And we looked at the MRI endpoint. There was a 40% reduction in in MRI lesion volume, but there was so much variability it didn't reach statistical significance. So it failed at the primary endpoint. But debris was caught in 99% of the filters, and 25% of particles were at least 1 millimeter in size. So there's a lot of debris that goes to the brain, and based on the debris capture and also the fact that clinical strokes, at least at the 72-hour point, were reduced, the FDA did approve this device. And I think it was a numbers issue, and MRI is maybe not the right thing. This was in a meta-analysis published in JACC, where they looked at all of the randomized trials with embolic protection. And when you look Every trial, the numbers have been better, lower stroke with embolic protection than without. None of them were powered or were large enough, but when you combine them in this meta-analysis, if you look at death or stroke, it was lower with embolic protection. So I think there may be a role. We might not have the ideal device yet, but I think that's one of the advantages of TAVI and TAVR is it's allowed us to continue to iterate, to potentially continue to lower these complication rates. As I said, bleeding rates have gotten less with this and things like that as well. So what's really been achieved is a new therapy and really a disruptive technology, improving clinical outcome, changing guidelines as a result of our randomized data, improvement in imaging, a dispersion of the technology. There's over 500 centers in the US that are doing TAVR now, development of the heart team, and much more. But there was a lot that was required to get to this point. Innovation, as we talked about with the devices and imaging, ingenuity, and operators willing to take risks. You know, these initial results were not great, so people had to push the limit and be willing to fail. But it was truly the collaboration between cardiologists, imagers, surgeons, and interventionalists and industry that helped really move this forward. And the heart team has been one of the important aspects of it, this teamwork, not only for the preoperative assessment saying who's a good candidate, but for the procedural aspects as well. And this heart team has been incorporated into the guidelines. It's a class 1 indication in the guidelines for a patient to be seen by the heart team and in the center of excellence. And we really need a heart team because people are arguing, you know, there's a lot of, we were talking about this before, yeah, everyone has their own vested interests, and people, not because they're selfish, but because of what they're trained in, may feel that their decision is best. And in complex cases, different perspectives can help. I'm going to move through a lot of this, but there's factors that affect it, right? There's a dominant position in the US, we see one institution, the surgeon's strong, and the other, the interventionalist is strong. And you see that sort of change. But team strengths and weaknesses can be different, hospital politics, but finances as well. And the heart team has really evolved. You know, in the beginning it was just about risk, who's not a good candidate for surgery, and then moving and putting that patient for TAVR, whereas now it's evolved to, you know, what is appropriate for that patient. But we really can't get rid of the team, because if we abandon the team aspect, you know, that conversation about durability may not happen. That conversation about stroke, about a second surgery, or if somebody has left main disease, is it appropriate to do a stent and a TAVR, or is the patient better off getting a CABG AVR? And those conversations have to be open, honest, and not that an individual physician, not that I as an interventional cardiologist can't give it a correct perspective, but each individual and each physician is going to come from a different perspective, and those conversations need to happen, and we don't want to sort of do that. And the heart team has got to evolve, and there's a lot that we got to go forward with TAVR, and I'll skip there. So bicuspid valves, concomitant CAD, those are all still unanswered questions that we have to move forward with. And we will need to do more trials. We have to look at a lot of things as we move forward. But I think from the Indian perspective, how do centers become a structural interventionist? And that's one of the biggest challenges, and perhaps worth discussing. You know, in the US, a lot of our fellows are doing a dedicated structural year. That's difficult here. There isn't volume, there isn't opportunities to do that. And it's industry that's going to provide this in courses like this, where we share complications and we share learning, where things move forward. And I think, you know, whereas PCI in India, there's huge volumes, this needs to be concentrated in centers where people can get enough experience and can maybe do 50 cases a year to maintain an experience and a volume. And I think that's really important. And in the US, it's obviously grown, as I said, over 30, now close to 50,000 TAVRs last year. Expansion to low risk is continuing, and data is lacking in some subsets such as bicuspid and CAD, but we have to continue to move it forward, and we have to continue to maintain the heart team. Thank you very much.
So thanks, Susil, because most of, he has made my talk much easier by telling most of the aspects of TAVI in the previous presentation. At the same time, I would like to tell, like a country like India, where the mortality means where the life expectancy is something low, to get TAVI done at the age of 70 is very difficult. So we are moving towards more like 60 or 65. Okay, the Sapien 3 valve actually comes packaged with introducer sheath, the commander delivery system, the valve, there is a balloon dilatation catheter, a crimper, and the inflation device. Now this valve is a bovine pericardium valve which has an inner skirt that is made of polyethylene tetrafilate, and now it has an outer skirt in order to prevent paravalvular leak. The height of the frame is quite low, so as to have a lot of advantages which I'll be discussing in short time. The valve struts is actually made out of cobalt chromium, and it has the widest struts on the top, which actually helps in decreasing the profile of the valve. And in between there are 4 struts made which actually increases the radial strength, and the lower portion again becomes wide enough. This is to decrease the fatigue and other resistance at the annular level, as well as to improve the radial strength so that the circularity is maintained. Now this is a balloon expandable valves, and all balloon expandable valve we size it based on the area, and depending upon the area the valve sizing is done. Now this valve, when crimped, is it comes in 23, 26 and 29 millimeter. Now 20 millimeter valve is also available, and the crimped height is something like 24.5 millimeter, 27 millimeter and 31 millimeter respectively. The valve force certains by 6.5 millimeter, 7 millimeter and 8.5 millimeter respectively for their sizes, and the expanded height so decreases to 18 millimeter, 20 millimeter and 22.5 millimeter. The inner skirt ranges from 9.3 millimeter to 11.6 millimeter, and if we try to subtract that 25% and come up, then probably that is how we come to a coronary height, required coronary height to be something like 9 to 10 millimeter. It has an outer skirt which is lesser than the inner skirt, and this outer skirt helps in preventing paravalvular leaks. The commander delivery system is a very user-friendly system, and it flexes at the distal end. It has a flexing mechanism at the distal end. This is just this helps us to track difficult aortic anatomy. At the same time, it also prevents in scratching the aorta as you are tracking the system, the delivery system of the aorta. You can actually flex the distal end by moving this knob. The fine position, you can fine position the valve by moving the fine positioner which is at the distal end of the system, and you can accurately position the valve as per your choice. Now the system has a taper tip. This helps to decrease the profile while you enter into the sheath and into the aorta. The valve, the balloon actually has a triple marker. The central marker doesn't, you cannot see the central marker outside. You can only see under the fluoroscopy. And then there is the valve that has to be loaded over the flex sheath and all. The commander delivery system actually comes with the balloon, which is different for different size of valve, 23 millimeter, 26 millimeter, or 29 millimeter, and the length of the balloon differs accordingly. Let me just introduce you to the system. This is the lumen to which the guide wire comes. This is for balloon inflation, and there is an indicator how much volume should be there in the inflation device for each valve. This is the indication for the default place where you start after you have loaded the valve, and this is locking mechanism, balloon locking mechanism, and this is one for the fine adjustment, and this is logo to tell like this portion should be up while you are pushing the seat, the delivery system inside. There is an indicator for how much flexion you have made at the tip, at the distal tip, so you can actually track, keep a track on that. The eSHEATH has a dynamic expansion mechanism by which the valve is larger in size than the 16 French if you are using a 29 millimeter, but as you push through the valve, the sheath slowly expands, and as you move forward, it again comes back to the normal size. So this helps not only in decreasing the size of the sheath, but also while retrieving in case you don't want to deploy the valve. This comes in different sizes, and there is no color coding for 23 and 26 millimeter valve, but there is color coding for 29 millimeter, which is green. The whole sheath is a very hydrophilic sheath, and when you start inserting, you need to activate the hydrophilic coating by just wiping with a saline. And the sheath has a fully expandable portion which should be totally into the artery as you place the sheath, and a partially expandable portion which can be outside. The balloon catheter comes in different sizes, and the one with 23 and 26 you need a 14 French sheath. For a 29 millimeter you need a 16 French sheath. Different volumes needed for the inflation devices mentioned, and the nominal pressure is around 4 atmosphere, rated burst pressure is around 6 atmosphere. But the balloon expansion is a volume related thing, not a pressure related thing. The crimper comes with a coil crimp accessory device which actually protects the valve leaflet while you are crimping, and it prevents from damage. It comes also comes with a different color coded stopper so that you can actually crimp the valve. This is the inflation device. For 23 and 26 millimeter you have a pressure monitor, but not for 29 millimeter, and this is a volume based inflation. It's not a pressure based inflation that you keep on seeing out there. It has a lock and unlock mechanism. So once you put your contrast saline inside, you need to lock it so that the volume maintains over there. It has a graduation mark of 1 millimeter, so volume accuracy is there. So you can actually decide how much millimeter you want to go up or how much millimeter you want to come down. Sushil has already talked about this. You need a good hard team, and you need to discuss the case properly over there. Justify that you are actually doing something indicated. It's not only that, you need to talk a lot about the financial matters. Like it's not only that you put in a device and you don't have a complication, you can have a complication. So those things also has to be talked. These are normal equipment required, and almost all the labs will have. But to tell a few, you need to have a extra pacer in case one of your temporary pacer goes down. You need to have a power injector, cardio bypass machine, when you are starting, particularly when the annulus is heavily calcified. And the other things are quite normal. You have a series of checklist of wires that needs for normal 035 guide wire, extra length wire, extra support wire. You need to have some backup mirror as well as Lunderquist wire in your artillery. The balloons for pre-dilatation as well as if you think of post-dilatation, the sizes should be adequate. That should be decided before you take up the case. And the sheaths, different sizes sheath, different sizes of catheters, particularly most of the lab which do simple cases, they may not have AL1 catheter. That's the one most of us use these days to cross the valve. And then in case of complication, to handle those complications, these covered stents, aortic balloon expandable stents, and all those things has to be there in the lab. At the same time, you should have a surgical tray ready in case anything goes wrong. You should be able to control the disaster. So when you decide to take up the patient, the general procedure is scrub the patient as if you are going to take up for a surgery. And you put in a central line from the right side. You can either put a temporary pacemaker from here itself, or you can take the femoral, whatever is your choice. The patient, nowadays most of us are doing conscious sedation, so esophageal echo I don't know, you can have it if in your first few cases. That helps us to understand how the valve is placed and all those kind of things. The patient is intubated, and actually I have another talk which is complication, annular rupture, but Sangeeta Velu had presented yesterday, so I'll be skipping that. So I'll take some time over here. So the patient needs to be intubated. If you're doing under condenses sedation, you should decide beforehand. So these are the things that needs to be there: the pacemaker, the catheter, triple lumen, or you can have a PA catheter. You need to have a pigtail from the one of the groin, so that you do the first initial aortography and see how densely the valve is calcified, what are the movement of the leaflets, etc. The rapid pacing is one of the important thing that you should know if you are doing a balloon expandable valve, and you should pace to an extent so that the systolic blood pressure comes down to below 50 millimeter of mercury, and the pulse pressure comes down to 10 millimeter of mercury. When you are looking at the rapid pacing, it should be a 1:1 pacing, and this is essential. Otherwise, the valve will just move away when you are trying to inflate, and that is essential and the most important thing that you need to look. The valve sizing is essentially done by CT these days, and as Susila has already told, it's not a circular structure, and at different level the valve size is different. It's an oval structure, particularly the bicuspid valves, where most of the valves are oval, and you have a difficulty in deciding the sizes. The valve sizing is done, as I have already told you, it's done depending upon the area, and there is some overlap between the two different valves that can be used. So how do we decide whether to take a larger valve or a smaller valve? A smaller valve is preferable in places where there is severe annular calcification, or there is narrow root and low coronary ostia, narrow sinotubular junction, mitral annular calcification, procedural aorta, or the leaflet is very bulky. So what do? We first take a puncture on the contralateral side, put in your 6 French sheath, go up, crossover, inject, and then you see the exact site of puncture where you want to take. Place a ProGlide, and then you need to start thinking of placing the sheath. But before that, you can put in a pigtail right up to the aorta, and then just to try to get the coplanar view. Now, coplanar view you can also get from the CT scan. It's not necessary that you get it from here. Now, how do we get the coplanar view? Now, NCC and the non-coronary cusp and the left coronary cusp are always in the same plane. All you need to track is the right coronary cusp. So if the right coronary cusp is towards this side, you just move your C-arm towards the RAO position, and it will slowly come towards this side. If it is on the LCC side, you move towards the LAO, and it will move towards the inner thigh. If the RCC is below like this, then you need to move your thing slightly in the caudal direction, whereas if it is above, then in the cranial direction, and you come to a position. But most of the time nowadays we get to the CT, and we just need some fine adjustment to come to a good position. Now these are the things we need to take into consideration about the patient: how bad the patient is, what is the size of the annulus, decide the valve pre-procedure. Intra-procedure, you decide whether you want to do the valvotomy or not, what is the orientation of the valve, whether it is correct or not. The fluoroscopic angle I have already discussed, and any other extra anatomical things you need to see before you do the case. And of course, if anything goes wrong, what are the things you are going to do to control that? So vascular access, yes, Susila again have already told this, whether a cut down or a percute depends upon the center. And nowadays, most of the centers are all doing percutaneous closure. So when you decide to take the puncture, the most important thing is the place where you take the puncture, there should be no calcium over there, because your sutures are not going to hold on to a calcium. You should also decide by the amount of tortuosity if the side less tortuous is the one that should be chosen while you are taking. So when we insert the sheath, now you have taken your ProGlide, everything, you want to insert the sheath, you should make sure that the E logo is facing upward while you insert the sheath. And as I told before that you need to activate the hydrophilic coating while you insert, before you insert it. If there is any difficulty at the same time, you can keep propofol or glycerin ready in case you need. So I always tell that if you want to insert a larger sheath, it should be on a very wire such as either Londoquist or backup mirror or Supracore or any kind of super stiff wire so that the sheath passes easily. In case there is any difficulty, you can slightly put a traction on the wire, and that will help in straightening out the vessels, and it will make life easier for you. All the these procedures should be done under fluoroscopy, screening, looking at like there is no complication while you do this thing. Okay. This slide I'll just skip through. After that, you need to cross the valve with a AL1 catheter. That is the most preferred. I prefer to use a regular wire rather than a thermo wire while I cross the valve. The choice is yours, but it is always a straight tip wire. And then it is exchanged over to Ampla super stiff wire, which initially we had to shape it. Now we have a pre-shaped wire, so whatever you can use a confida wire instead of that. But if you are pre-shaping, if you are shaping yourself, just make sure the joint, the connection, the area of connection, you actually shape beyond that. Otherwise, that may go into the ventricle and can cause ventricular rupture. So this is what I want to tell. The transition zone should always be included after the curve. So then what we do is we'll crimp the valve, and after while crimping the valve, there should be a second person in the room who comes and who checks it. It's that person's job to see whether the orientation of the valve is correct or not. So the inflow person and the outflow person should be correctly put while it is crimped. Take the volume wise, you put the correct volume into the inflation device, and then you can decide whether you want to do a BAV or not. So there are conditions where we want to do BAV, and if the valve area is too low, definitely we want to do it. If you want to evaluate the coronaries, we want to do it, and at the same time you want to take an aortography to see if the coronaries are getting occluded or not, and what is the movement of the valve. If there is severe septal hypertrophy, then you need to see how much depth you want to keep. At the same time, if there is a mitral prosthesis, it's always better to do a BAV and aortography. Similarly, if the leaflets are severely calcified, you need to do a BAV.
Amit, please finish in the next minute.
That
I know, but I think we are going to be going over time. So actually the sequence actually was to talk about Sapien 3 valve specifically. So stick to that, and then we'll go for Evolutar.
No,
and then when we have time, we can discuss more about
I was actually not planning to give the next talk. That's why I'm taking up that time.
Yeah, we still have to give that talk.
So you can BAV while you are doing, you can just have a primary operator and secondary, and the pacemaker guy has to coordinate. You need to load the valve, and then I'll just skip through this because we have already discussed much of this. You can precisely position the valve by opening the lock and then moving the fine knob, and then position the valve in place after the valve comes out of the sheath. Cross the valve, track the valve using the flex sheath, cross the valve, and after you cross the valve, you need to pull back the flex sheath. So what you do is you just unlock, pull it back, and after it comes back, you are ready to go. How do we position the valve? Okay, let me just come directly to that. The valve should be positioned at the central marker should be at the level of the cusp, and then you can make fine adjustment using the knob. After that, you deploy. How do you deploy? Deploying is a process, it's a coordination between the first operator and the second operator. And the primary operator is the one who tells pacemaker guy to operate the pacemaker. When he sees that the capture is 1:1, the systolic blood pressure has come below 50 and pulse pressure is below 10, he tells, and the valve is in position, the second operator inflates the device and counts to 3 seconds. That is 1001, 1002, and 1003, and then deflates, and after that, the pacemaker is put off. After deployment, you need to check certain things which we have discussed in a lot of time in most of the places, so I'll just skip those slides. Post-deployment, AR is checked and all. After that, you need to remove the delivery seat. Just pull back the triple marker into this seat and remove the delivery seat. Remove the seat, but everything should be done with the Edward logo facing upward. And then you do the vascular closure. Thank you very much.
So Evolute R was one of the valves from Medtronic which was available to us quite early in India. They started at the core valve, but initially, and then quickly we had the Evolute R valve. And our TAVI program in India is now mostly done with the Medtronic Evolute R valve. And as you know, Evolute R valve is comprised of, they have 4 sizes, 23, 26, 29, and now 34. Recently, Evolute Pro has also been introduced, but it's just not still approved in India. So there are 2 delivery systems, a 14 and a 16 French equivalent, and the 3 loading systems depending on the valve size. So it's got a self-expanding frame. You can look, the valve has such as a capability of recapturability up to 80% of deployment. And the valve has a supra-annular valve design. The valve is above the native annulus. And it's got very thin, low profile delivery system. I think one of the lowest profile available in the market. And it comes as 4 sizes I told you. And again, there is a chart by the company depending on which we select these appropriate valve sizes depending upon the annulus diameter, and particularly using the perimeter for the self-expanding Evolute R valve. So we look at the perimeter based on the CT measurements, and based on this chart decide on the appropriate valve size. Again, there are some limitations to this. For example, the bicuspid valve, I think there are some different views of choosing the valve size when it comes to bicuspid valve. Again, importance is given to both the, I think we listened to Dr. Sushil's talk on the importance of the sinus diameter, which is more important than the actual coronary height. So we have to make sure they have adequate diameter and the sinus heights. The delivery systems, as I told you, it's one of the lowest profile delivery systems available in the market today. And this is a 14 French inline sheath, which again is the lowest profile. And for a 34 millimeter, you have a 16 French inline sheath. And in situations where we don't have to, if we have a big access site, we can have also the option of putting in a sheath. We need a 18 French for the size, and for the 34 millimeter, we need to have a 20 French sheath. So the capsular flare is again one of the important features of the Evolute R valve. It enables a uniform and controlled valve expansion into the annulus. So initially, the valve as it's loaded, I think very important, before even doing a balloon valveotomy, it's important to check whether the valve is loaded properly. So it is a cine, a fluoroscopy and a recording is done, and valve is rotated to look at whether the valve there is any misload. Particularly look at the paddle and make sure there is no large gap between the paddle and the pocket. This is the correctly loaded valve capsule, and here there is a large gap. The paddle is out of pocket. And also when you look at whether the asymmetrical, the outflow crowns should be parallel to each other, and there is no loss of parallelity again indicates misload. So it's again you have to look for any other uneven marker bands or any visual anomalies within the capsule. So it's again very important to make sure the valve is loaded well before we start doing the BAV. And once, depending on the patient, you decide to do a BAV or do direct implantation, and then the valve is taken, making sure that it is under fluoroscopic guidance, the valve is tracked down, crossed into the aortic valve, and as was pointed out earlier, achieve coplanar imaging projection. And here there is one more feature which we can achieve easily using the radio marker band. The marker band it should be alignment is can be done by increasing the caudal or depending on the view and making sure the radio marker is well in a single straight line to avoid parallax. And once that is done, the deployment, the ideal target deployment depth is 3 to 5 millimeter. Here the node 0. Node 0 is the lowest point and the node 1 is 6 millimeters above. You can see the band there. So the ideal depth is midway between the node 0 and node 1 and just below the node 1. So this is what is recommended, but again it varies depending upon the different scenarios. We make a very little higher deployment, and the start deployment at a target depth of 3 to 5 millimeters. And again, the pigtail, as probably you all know, it is kept in the non-coronary sinus to make sure it's the lowest point in the aortic sinus, and that serves as a marker. And once the valve is kept in the target depth, and it's slowly started to deploy. And the deployment is by first 1/3 of the process is done by rotating very slowly, extremely slowly, so that the valve does not move either inside or comes out. And while monitoring under fluoroscopy, and whether the second operator gradually deploys the valve, the first operator makes sure that he holds the valve catheter in position. And once the 1/3 is deployed, the second 1/3 is deployed quickly. This is because sometimes can cause temporarily there may be a drop in cardiac output and hypotension. So once that is done very fast, and as we go near the point of no return, that is the marker of the paddle attachment where that is a point of no return. So as we go near that, there is both the tactile indicator as well some noise which indicates that we are nearing the point of no return. So we need to once the pressure stabilizes near that, and we need to stop at that point, and to make sure we can do an aortogram to check. This is near 80%, and beyond which one cannot retrieve it beyond that. So we can't recapture. So it's important to check everything, and also it's important to release the system tension. Here, if you see this figure, it's more towards the inner curvature of the arch, and this might not result in a good position. So it's important to give pressure and make sure a little bit of push slightly, and to make sure the valve is aligned towards the outer curvature of the aortic arch. And this can be done by either a slight push or even by retracting the wire a little bit. So as in this example, so this is a patient this is actually a bicuspid valve which we were just releasing the valve. This is almost near the point of no return at the 80%, and if you could see, this is almost on the left side it is quite deep. On the right side it looks about 0 to 1 millimeter depth, but you could see that it's more towards the inner curvature, and we are trying to push slightly to move towards get a better alignment. So we are actually pushing the whole system and waiting for some time. And if we deploy it in this position, there is a possibility of either valve jumping in, and maybe there's a lot of calcium here. The valve might jump in, maybe too deep inside. So we are giving a good push, and you could see this. There's almost a lot of pressure, and then we are able to release it slowly to get a good position. So prior to withdrawing, once we then complete release valve is released completely, and making sure that all the paddles are completely released slowly, and next 1/3 should be very slow release. And once the paddles are relieved, the valve is in position, and now we have to close and remove the system. Prior to withdrawing the system to the descending aorta, we have to make sure the catheter tip is coaxial with the inflow position. Otherwise, we can cause the valve to pop out. So we have to pull the wire a little bit, making sure it becomes coaxial, and then you can take out the nose cone, and then the gray knob is brought towards the blue knob by retracting it. And once that is done, the system can be withdrawn. Again, you have to make sure whether it is properly captured. It's not over captured. By looking at this image, you know this is a properly captured valve. So then the inline sheath is completely removed, and then if you want to consider post-dilatation, one can put in a 14 French sheath, and then make the hemodynamic assessment, and then if required, post-dilatation can be done. So post-deployment, actually, ideally, even there is a PVL, wait for 10 minutes to make sure the valve expands very well, and then decide whether post-dilatation is required. And depending upon both the echocardiography, the aortogram, and also the hemodynamics. And if post-dilatation is required, you can size the balloon to minor axis, making sure not to oversize the balloon. If you want to be a little more aggressive, you can use go up to the mean diameter of the annulus and perform post-dilatation. And in case the valve is not in a good position and we want to recapture, we can do it, but it's the company recommends to recapture 2 times, and third time it has to be removed from the body. So recapturing is quite simple, just the opposite movement, like how you release the valve, and once the valve is recaptured, you can insert it back and position it again, and then you can again start deploying the valve. So the device success is defined as assessed by TEE, iotogram and the AR index have good results after valve deployment, and successful vascular access and delivery and deployment of the device, and successful retrieval of the system, correct position of the device in the proper anatomical location, and the gradient less than 20 without moderate or severe paravalve leak, and only one valve implanted in the proper anatomical location. So I'll just show you an example of one of our cases. This is a 67-year-old lady who had severe calcific aortic stenosis with class 4 symptoms. She has known hypertensive and rheumatoid arthritis. She had come to a hospital for TAVR. While she was waiting and we were assessing her for TAVR, after the CT, the next day she had a cardiac arrest while waiting TAVR, and she had a very high risk for surgical AVR with a STS score of 38.34. So following the cardiac arrest, she was unconscious, and we had to assess her brain status. And following the neurological clearance, we decided to perform an emergency transcatheter aortic valve replacement. The CT showed a perimeter of 73, which is more in favoring a 29 millimeter valve, and the left coronary heights were 9.5, little on the lower side. The right was 14.5 with adequate femoral diameters, but the sinus of valsalva diameter was quite roomy with adequate heights. So and the femoral artery were around 6 millimeters. So we decided to go transfemoral, and this was a bicuspid valve with quite significant amount of calcium. So we considered to do a pre-dilatation and the amount of calcium. So the groins were the adequately sized, and the LV aorta looked quite favorable. So we crossed the aortic valve. I think I'll move on to once we cross the aortic valve.
Can you get the slides back, please?
Yeah, slides.
I think it's down there in that connector.
Is it something to do with this? Okay, got it. Okay, we crossed the aortic valve with the AL1 and a straight wire, and the pigtail and the non-coronary sinus. And this, before we perform the BAV, we make sure we loaded the valve, check the loading, as I pointed out earlier, making sure there are no misload. And once we are satisfied with the valve loading, then we perform a BAV, and we injected to making sure whether we are. It is a bicuspid valve, so we wanted to do a pre-dilatation, and also check the iotogram during balloon valvuloplasty. And we decided for 26 millimeter valve in this patient because it's a bicuspid valve, and we measured at different heights at 5 and 8 millimeter cuts. The perimeter was well within the 26 millimeter range, so we decided to take a 26 millimeter evolute R. So the valve, as we are tracking the valve, we are doing a fluoroscopy in the LA view to making sure that the valve tracks smoothly without causing any injury to the aorta, making sure the valve tracks very smoothly. And once the valve enters the annulus, it's just kept at just below the position, and then slowly started to start deployment. So we are just starting to deploy gradually, slowly. The second operator slowly starts deploying the valve, and at this point we realized that the valve is actually moved little up. It looks like it's come up to almost at level 0. So we don't want to deploy at this position because it's a very high risk of pop out. So at this point, it's easy to retrieve the valve. So we decided to retrieve the valve again and reintroduce the valve, and then start the deployment again. And this time we are again slowly deploying. making sure it is just at least about 2 millimeter, 3 millimeter depth, and then the valve is now, at this point, we go up to the 80% deployment and checking whether the valve is in good position before we do the final release. And this is the final release. We make sure the paddles are completely released slowly, and then we do an iotogram, and we remove, we make this nose cone coaxial, and then slowly remove it. And there's an iotogram to check whether we also check in the many other projections to see the valve, whether the valve is opened up well. There is some amount of narrowing in other views. So after doing an iotogram, we realized that there is some amount of paravalvular leak. So we decided to do a post-dilatation with a 20 millimeter balloon, and following which there is the final valve looks good, and there is no PVL as assessed by transcriptional echo and by hemodynamics. So to conclude, Evolute R valve it's a really good, very friendly valve with a very short, no, I would say short learning curve, and we have been using this for quite some time in India since last 2.5-3 years. So we've got very lowest profile delivery system with a wide range of sizes. The main advantage, I think, is to be our 80% recapturability and the supravalvular annula design. Thank you.
So I'm going to talk a little bit about sizing and by echo and CT. And we've talked a little bit, why we need to size correctly. You're going to get proper valve function if you size correctly, but the key things in terms of acute safety is anchoring and sealing. So we've learned a lot, and I won't belabor it because we've talked about it a little bit, but it is a three-dimensional structure. It is not a circular structure, and it's going to vary from patient to patient. In some patients, more elliptical than others, and so you need a 3D assessment of each patient. The one thing I will say is, ideally, in most of the sizing algorithms have been based on systole. There are some groups that have sized on diastole, but in general it's been systole. And that's relevant because most of the cardiac CTs that if you send to a radiologist to get a cardiac CT, they're going to do prospective gating and give you diastolic imaging because they're used to looking at coronary arteries. And coronary arteries you look at in diastole. And so you want to make sure that you get the entire phase and you get the systolic imaging in these patients. And again, you're going to try and define the anatomic structure of the root. And whether you do this on echo or on CT, you want to get a center line perpendicular, and you want to measure from the edge of one, the insertion point of the right cusp to the other side. And that's if you're doing it on biplane TEE. The reality is, the reason that biplane TEE works, even though it's not a three-dimensional measurement, people have looked at this. When you look at the mean diameter, in general, it's pretty close to this parasternal long axis, where it goes from the right coronary cusp here and to the commissure between the non and the left. That is not the minimal diameter. Often that tends to be the mean diameter. And that's why we got away with it for so many years, even though we weren't doing a three-dimensional reconstruction. But the reality is that the most accurate way is to do it, because no single diameter can characterize the elliptical nature. And it is very commonly oval-shaped, and in one analysis, the mean difference between the coronal and sagittal measurement was 3 millimeters. And so you can see that. And this is an example of one patient that is published in JACC by the group from Vancouver. On 2D, it is a 22 millimeter annulus. But if you look at the CT, it's 22 by 28. So if you put a 23 millimeter valve based on that 22 annulus, you're going to grossly undersize the valve, and you're going to end up with severe leak. And that's why you really need to get this three-dimensional measurement in these patients. And the annulus is not a anatomic structural, it's a virtual structure. But you're not just measuring the annulus, you're measuring the STJ and all of those structures. And if you get the angular diameter, that's one number, but we generally use perimeter and area because that better represents the three-dimensional nature of the annulus. And so rather than a 2D measurement as what you see on the bottom, you really want this three-dimensional measurement. And the goal of the pre-TAVR CT is mainly to assess aortic annulus size, but also the surrounding structures as we talked about. When we're talking about coronary obstruction risk and other things, you need to assess the entire complex, STJ calcium, right? We've had patients with a porcelain aorta, and they have an STJ that has a circumferential ring of calcium and a diameter of 20. When you put a 23 millimeter valve, if you have a short sinus, the deployment balloon for that 23 millimeter valve will hit that STJ, and maybe it'll injure it, or maybe that balloon won't expand and it will watermelon seed the valve down towards the ventricle. So though you need to look at those potential risks for complications. You want to look at LVOT, calcium, and other things. Then beyond the valve, you want to assess vascular access. But when you're getting this scan, you want to minimize the harm to the patient. Now, radiation is a risk, but I think in this elderly population, the dose of radiation from the CT is not that significant. But the IV contrast more often is not. Many of these patients have reduced renal function. I'd say a third of our patients have a GFR less than 30. So we are really sort of pushing the limits on this. And so for the pre-TAVR CT, there are really two components. There's the cardiac, which is what we typically do is an axial scan for that. And then the vascular, which we do as a helical. And I'll go through that in a little bit. But in terms of the cardiac scan, you want to make sure you get the entire complex. So we want to go from the STJ at least. So minimally, you have to capture the STJ and then also get the most caudal portion of the heart. So you want to be able to see the apex. In some, you can get the aortic arch, and others we don't. I would say you want at least 0.5, 0.6 millimeter slices, and you need IV contrast. The scan length is what you have to consider. If you're using a 64 slice scan versus a 320 slice scan, that's relevant. Contrast dose, radiation dose, and the scan must be gated. And ideally you do this with a breath hold because you want to minimize motion artifact. Depending on the patient's ability to cooperate, how sick they are, their heart failure status, they may not be able to cooperate fully for a breath hold. And again, we don't do prospective gating. I don't focus on these the radiation dose is relatively small, and I want the entire cardiac cycle. I want all phases. But if you're going to do prospective gating, I would focus on the systolic phases as well. I think most of you are familiar with how a CT scanner works, but basically, obviously there's an X-ray tube and there's these detectors. What's really relevant is the detectors. When we talk about 64 slice versus 128 versus 320, that's what's relevant. Because when we're talking about helical scanning, what helical scanning is, it's a continuous. There's lots of overlapping data. The detectors just continue to rotate and the patient moves through the scanner. And in the past, this was used for cardiac CT. But it's lots of data, lots of radiation, and lots of overlapping data, unnecessary radiation. So generally for cardiac CT, we don't do helical scanning for the most part. And most of it now is this axial. So axial scan, you get one scan, then you move, the X-ray tube's off, the scanner moves, then it gets the next. So you want to make sure that you get, you need to step as much as you need to get the entire field. So if you're doing this the entire thorax, you're going to step multiple times. This is what we use for cardiac CT. So when you're talking about a step and shoot scanner, and this is some of the technical stuff, but I think it's important to go through, because when I was talking to my radiologist before, I didn't understand what the limitations and considerations were and what 64 versus 320 really meant. But generally, you need about 15 centimeters of craniocaudal length to get the structure of interest, to get the valve to the apex of the heart. You need about 15 centimeters. And depending on the number of, depending on your scanner and how much coverage each step has, it will depend. But each acquisition is a volume. And so with the usual width of a detector row is about 0.5 millimeters. So if you have a 320 slice scanner and 0.5 millimeters, you can get 16 centimeters. You will get everything in one acquisition, right? So this is what I mean. So if you have a 64 slice scanner, you have to do 4 acquisitions to get the entire craniocaudal length. And so that each acquisition, you get a risk for, especially in AFib, the sync may not be great. So if you have to do multiple acquisitions, that's where you get splice artifact. You get more artifact when you have to do multiple acquisitions. In addition, you have to give more contrast. So you have to make sure contrast is going through these entire 4 acquisitions. Each acquisition is typically 1 to 3 seconds between the stepping and the acquisition. Whereas with a 320 slice scanner, there is no splice artifact, because in a 320 slice with 0.5 millimeter detectors, you get 16 centimeters. So if you have a 320 slice, you get the entire heart in one acquisition. And also, you can reduce your you can reduce your contrast use. And so what we've created are protocols with 40 and 60 cc's of contrast. We get our cardiac acquisition as well as the vascular. And that's because we do it on a 320 slice. There are dual force scanners that can, modern scanners can reduce contrast to 40 to 60 cc's for these TAVR CTAs. And so, as I said, what we generally do is the one we're using is a 320 slice, one volume for the whole heart. And so we can minimize our contrast use. We can get the cardiac with less than 20 cc's of contrast. If all we want is a cardiac and we time it appropriately, we can get it with less than 20 cc's. So there's a lot of logistical considerations. Do you need a dedicated scanner and the scanner location? Who reads the scan? And the other thing is, for us, this is an issue. We see about 15 to 20 AS patients in our clinic. We get scans on these patients. If you scan 70 and 80-year-olds, you find a lot of unintended lesions. And what do you do with them? You have this 2-centimeter pulmonary nodule, or this. I didn't know what IPMN was. It's this benign slow-growing neoplasm in the pancreas. We see that so often, at least once or twice a week. We don't do anything about it now, but somebody has to follow up with all these results. And then you want to analyze it. As I said, you need to analyze it yourself. Vascular access is pretty straightforward, 3D reconstructions, all of the different, we use 3Mencio, I think a lot of people do, but all of the, Philips, GE, Siemens, they all have their analysis package. Their Circle Imaging has an analysis package. But the goal is the same, to do 3D reconstructions. And whoever's doing the case has to do it along with the imaging expert. And then the key is you want to find the annular plane. This is a nice review from Marcus Castle. This is done using free software on the Mac, Osirix. The idea is to create two perpendicular planes. If you create two planes that are perpendicular and you get double obliques, you're going to create the third plane perpendicular to these two is going to be perpendicular to the valve. And so and then you can step down to the annulus. And so you just sort of rotate around. What you do is you rotate these around and make sure you're still perpendicular to the annulus. So if you rotate these around about 20 degrees each time and get perpendicular, you'll get a annular plane. And then you make sure you're perpendicular and you go down slowly all the way down to the annulus, and you get your annular measurements. And then when you get down to the annulus, you want to measure mean diameter, area, or perimeter. We generally use area and perimeter. I don't use mean, although some people use the mean diameter. Then you want to look at other factors such as coronary height, so from the annulus to the coronary, STJ width, STJ calcium, sinus width, STJ height. These are all measurements that are relevant to go into it. And as I said, coronaries, you can measure this, usually you can measure like this. Some people measure from here to there, an oblique measurement, but the idea is there room for the valve to sit? There's certain risk factors for coronary occlusion. Balloon expandable valves are higher in this initial analysis. Valve and valve was higher. But the reality is you just need to understand each individual patient anatomy, and you can use multiple things. But you have to understand what you're looking at. As I said, most people get diastolic phase imaging. Diastolic phase imaging, in general, because that's what we used to do with coronaries, is not as useful for TAVR. Diastolic measurements in general are 10% smaller than systolic measurements. This is analysis from the Vancouver group showing that the largest measurement is generally around the 20% phase. And so if you're looking at the 70% phase in general, that's the smallest measurement. So you want to get the systolic phase. And this is from Jonathan Leipzig, the same group in Vancouver, that in 20% of patients, if you use diastolic measurements instead of systolic, you choose a smaller size in this analysis. So that's dramatic because you have to size appropriately. So if in 20% the valve size would be off by using diastole than systole, that's an important consideration. And perimeter and area are not the same. Area is roughly 2 times perimeter sizing.
And these are all relevant. There's multiple analysis showing three-dimensional measurements can predict PV leak. So you can't do a simple 2D measurement anymore, and you have to do these 3D measurements. And I think they've really made the procedure have result in better outcomes. But the one thing I will caution is a bad measurement is worse than, sometimes worse than doing nothing at all, right? So if you're off axis and you measure the angles here, and here you see part of a leaflet tissue. Oh, my pointer's not showing. But in the top right screen, you see some part of the cusp. This is an inaccurate measurement. A bad measurement can be dangerous. In addition, look at the quality of your CT. If you have artifact, that can make things worse. Especially for elderly patients, there's a lot of motion artifact. But you can also, if you're using a 64 slice scanner, you can have step artifact. And in this patient, there's a slice artifact here, right, from a misalignment, and that's going through the annulus, and that's going to cause a problem potentially. And this is artifact from motion, right? These are all errors. So look at the quality of the CT. If you have a great quality CT, then I trust the measurement. If I don't have a great quality CT, I might not trust the measurement, then I have to use other factors. Either I repeat the CT, or I do the patient asleep and get a TE measurement, or I do balloon sizing. But if you don't have a good quality CT or your gray zone, you have to verify it with another modality, either TE or balloon sizing. And then getting to that, what about echo versus CT? Obviously the advantages of echo over CT, CT is a one shot in time. Echo has the advantage of temporal resolution, multiple heartbeats, and you can visualize the hinge points in real time as they're moving. It provides physiologic information as well, and also in terms of bicuspid or not, you see where the flow is. It eliminates the idea of motion-based artifacts since you are seeing as motion, and you get to view the adjacent structures in motion, and you get rid of hand tracing errors. But the pitfalls of echo are the lateral, the coronal plane is not good, right? That's where the dropout is in ultrasound. You also, especially when there's heavy calcium, which we see in some of these patients, you get shadowing and acoustic artifact. But also it's very operator dependent, and it's also more invasive, obviously. You have to put the patient to sleep and do it under TE guidance. CT, it has better tissue and lumen contrast, and it's less invasive. But it's prone to the stuff we talked about, motion, step artifact, multiple slice artifact, and suboptimal contrast in some of these patients. And again, the balancing the contrast load of CT with the risk of anesthesia with echo. But the same multiplanar measurements that we do on CT, you can do on echo. And you can see here, this bottom right panel, those are the same double oblique views that we talked about to get to the same angular measurement. It's just the same, it's just a different, but it's a skill set that must be acquired. And you see in this patient, we got CT and echo, same measurements. We've done an analysis, and they're in good hands. They're pretty close, but they are measuring different things. Echo, I think we're measuring a little bit lower in the LVOT than we're measuring on CT. So in this patient, it's 418 versus 396. But left main distance are similar. Aortic root are roughly similar. In the end, the findings are going to be a little different because you're measuring slightly different structures. You're measuring maybe a millimeter or two below. And many of these measurements are based on the location of the annulus. And you're measuring different things with echo and CT. And both are really probably valid. And there may be slight difference, but so don't be married to one modality, but be married to a good quality data set. As I said, a bad quality CT, good quality echo, I go with the echo measurement. So you make sure you look at the quality of the data sets that you have. And there's going to be a lot of factors, right? There's technical differences and limitations in individual patients. You might not be able to get a TE on some patient because they have esophageal issues. You might not be able to get enough contrast because of renal issues on a CT. And the quality is going to vary in the cardiac stuff. And so, you want to look at LVOT calcium and different things. And so in this patient, you see LVOT calcium nicely on CT. In this patient, it's in certain places the imaging is better than another, and you need to be patient with echo because you got to get rid of that calcium artifact. So in summary, CT I think is a more generalizable tool for planning. You want to optimize imaging while minimizing harm to the patient. And so you have to know your scanner strengths and weaknesses, how to maximize its abilities. You have to use the available analysis tools to optimize pre-procedural planning, and you have to understand the strengths and limitations of both echo and CT. Thank you very much.